Our final speaker today will be coming from, if we're lowest in the states in terms of all these numbers, coming from a state that's usually in the top five. So he doesn't have these problems. So this is Dr. Ben Schlechter, who's coming to us from Dana-Farber Cancer Institute. He did his medical school at Tel Aviv University and did his residency in fellowship in Hemonc at Beth Israel Deaconess Medical Center. He's currently an instructor at Harvard Medical School and a GI medical oncologist at Dana-Farber. And his research focuses on lower GI cancers, colorectal included, and developing novel immunotherapy treatments for these GI malignancies. And he'll be talking to us about novel immunotherapy approaches for GI malignancies. Please welcome Dr. Schlechter.
All right, thank you very much. So I'm going to try and cover a really interesting topic, a very forward-thinking topic. We're going to talk about no drugs that are currently FDA approved, and I think between 1 and 4 of them will be FDA approved within this decade, and they'll give us paradigms for how I think colorectal cancer and GI cancers can be managed in the future, and ways to think non-surgically and non-chemotherapy about these cancers. These are my disclosures. Importantly, we will talk about drugs from the company Agenus, which I've done consulting for, but only published in peer-reviewed data. So our agenda, we're going to talk about the biology, immunobiology of cancer. We'll talk about immune checkpoint blockade and GI malignancies, the next generation of immune checkpoint inhibitors beyond the ipi-nivos and pembros, and then finally cellular immunotherapy, which is, I think, where the field is going, and it's a very, very important topic. It's actually very relevant for this advocacy group. In Massachusetts, we're 1/5 the size of Louisiana, and we are more than twice the population. We're a very urban state, and these are intensive hospitalization-based treatments. And so for a rural state, it's very challenging to think about how to hospitalize patients and have them within 30 minutes of a hospital for a month from treatment with cellular therapy. The challenge of immunobiology in cancer is really complex. So number one, the immune system's role is to identify healthy versus unhealthy tissue, but the dirty little secret is that cancer and normal tissue are deeply similar. Number two, cancer isn't that different. And number three, the environment of cancer is profoundly dangerous to the immune system. So you can think of our effector T cells as a fish out of water. They just can't live in desmoplastic GI cancers. Even if there was a target, the T cells just can't get there. And that's because of very low pH, very low oxygen, profound fibrosis, and inhibitory cells in the microenvironment of these cancers. So the challenge is, how do we overcome these barriers? How do we destroy these regulatory T cells? How do we avoid harm to organs? And importantly, how do we essentially get an effector T cell in there? I think of immune therapy as 3 major drugs. There's the conventional pro-inflammatory drugs that are not as used anymore. This is the IL-2 and interferons that promotes inflammation. There's non-targeted immunotherapy. These are immune checkpoint inhibitors. People call these things immune therapy or anti-cancer therapy. Really, all those monoclonal antibodies work on immune cells and not the cancer. And then finally, actually creating targeted immunotherapies that hit the target we intend. And we're going to talk about those. So for our non-targeted immunotherapies, as we said, this is a targeting the immune system. This is immune checkpoint inhibitors. The only place they're really effective in common GI cancers is in gastrointestinal cancer. And we can see in metastatic disease, FOLFOX plus or minus nivolumab, there's a clear survival benefit for PD-1 positive cancers with CPS greater than 1%. And there's a benefit in advanced disease. There's an even greater benefit for gastroesophageal cancers treated adjuvantly following chemoradiotherapy and resection in early stage disease. And this gets this kind of like funny little thing about immune therapy. It's better in early stage disease. It's better for a variety of reasons. There's a limited contribution of an immune suppressive environment in early stage disease compared to advanced disease. The patients are fitter. Their T cells are better. We haven't done things to them with chemotherapy that injure the immune system. Whereas in advanced disease, these tumors live and survive because they create a vigorous anti-inflammatory environment. Chemotherapy injures the patient's T cells. The quality of the patient's organs is worse. The quality of their immune system is worse, and they have bulkier disease. If you have more cancer than immune cells, even if you have a good immune cell, it still can't win. And so if we see this graphically, we can see on the left that early stage disease is a 50% improvement in survival compared to a marginal improvement in overall survival for advanced disease. For the very rare mismatch repair deficient cancers, we now know that there's dramatic effect in advanced disease. We know it's true in early stage disease with the published NICE studies from Miriam Chalabi. These are brave trials that were done for MMRD cancers with nearly 100% response rate. And from Andreas Ursak at Sloan Kettering, 100% response rate for MMRD rectal cancer, which is rare. And the challenge of this is patients want it. and they can't have it is ineffective and dangerous for patients with MSS cancers, which is the commanding majority of cancers. If you look at microsatellite stable colorectal cancer, these drugs don't work. You can squint at these graphs all you want. You can talk to your MSLs and your reps. There is no benefit to conventional immune checkpoint blockade in advanced colorectal cancer. However, we have a new drug. And this is the first drug I think will be FDA approved in colorectal cancer as a new paradigm since 2007. This is an agent called botensilimab with balstilimab. This was published last year or about 6 months ago in Nature Medicine with Dr. Bullock and I. This is a novel CTLA-4 monoclonal antibody. So what this does is it tightly binds your antigen-presenting cell, it tightly binds CTLA-4, and it recruits NK cells. And this has a number of novel interventions. Number one is it more potently depletes regulatory T cells. If you have less regulation, you have more inflammation. Number two, CTLA-4 is not just on the peripheral T cells that you learn about in doctor school, but in fact, they're on all sorts of things, including myeloid-derived suppressor cells and fibroblasts and other such things. And so as a consequence, we can injure those infiltrating cells, those anti-immune cells in the tumor microenvironment to promote inflammation and to promote an anti-cancer effect. But it doesn't always work, and it doesn't work for special reasons. As you can imagine, a more potent injury to anti-inflammation promotes inflammation, and there's toxicity. This is a relatively average population. These are patients with a median age of 56 years old. This was an age range of 36-year-old to 82 years old. These were both left and right-sided cancers, BRAF mutated, KRAS mutated. This is a generic population. And we did see a lot of toxicity, in particular immune-related adverse events and colitis being the driver of toxicity. We learned throughout this phase 1 trial that early initiation of infliximab could keep more patients on trial and result in better outcomes, and ultimately these were our data, these are our results. This is the first report of an effective immune checkpoint blockade in microsatellite stable colorectal cancer. We saw no objective responses in the liver, only in extrahepatic disease, and we modified the trial to pursue this idea that extrahepatic disease versus hepatic disease are biologically different and need to be treated differently. The safety profile was important but manageable, and throughout the phase 1 trial, we were able to figure out how to do this. We've now completed a randomized phase 2, and we're waiting funding for the phase 3. And it really begs the question, should we be debulking the liver to make this an opportunity for patients in the future? The drug's not FDA approved yet, so we can't do that. But if you look at this these waterfall plots and spider plots, you can see the red guys have liver mets, none of them respond. The blue guys don't have liver mets, they respond. The green guys had prior surgery on their liver and achieved liver-free disease status and then responded with a significant response rate. So what's the deal with the liver? Why is this an issue? I think this is a really important question. It's going to be a driver of what we do over the next decade in immune therapy for colorectal cancer and other malignancies. The liver is one of the only organs when you do an orthotopic liver transplant where you can taper immune suppression. And tolerance is sort of the driver of the liver. The liver is meant to be exposed to all the things you eat and not develop immunity. So it is an organ of tolerance. And we think this may be driven by Kupffer cells, hepatocytes, endothelial cells, and other cells. There's some interesting older data on this. So if you take pigs and you give them skin grafts, they will reject a skin graft. If you give them a skin graft and a liver transplant from the donor, they will be tolerant to the skin graft. So the liver plays a role in systemic tolerance. If you take a patient with metastatic melanoma and you inject their liver with metastatic disease when they're responding, or I should say mouse, when they're responding to immune therapy, you will have failure of immune therapy systemically by injecting metastatic disease into the liver. So the liver is important. And we're now stuck. So here we go. So the way I think of this is that we believe it is macrophages, the Kupffer cells in the liver, are doing something different. Antigen-presenting cells process antigen, they create effector T cells, and they expand those effector T cells everywhere in the body but the liver. And in the liver, antigen-presenting cells process antigen, create a synapse with those T cells, and they run through that. And when that T cell says, I got this is a thing I can kill, the Kupffer cell kills it and creates tolerance. And so we need to address this. So this brings us back to our waterfall plot, why we see this special biology. In the liver, we fail, so we have to focus going forward on non-hepatic disease and begin to address mechanisms of failure beyond the liver. To further investigate this, we had a prospective randomized trial. It was a 5-arm trial of botensilimab with balstilimab, botensilimab alone at 2 different dose levels because of an FDA requirement for what's called contribution of components to make sure we're not doubling the price without any benefit to patients, and then standard of care chemotherapy. We're not going to go through too much of this. This has been presented by Marwan Faki, but Botensilimab 75 milligrams of balstilimab 240 milligrams was the winner in this. And what we can see is a similar distribution of responses. We have durable, deep, and persistent responses in refractory metastatic disease on the left. And if we compare our control arm of Lonsurf or regorafenib, we see no objective responses and no prolonged survival and no complete responses. It's a very compelling phase 2 trial. As an example of a patient, I treated a 50-year-old woman. She had a left-sided colon cancer, KRAS mutated. She presented with liver and lung metastases, underwent SBRT to the lung and resection of the liver, and she recurred. She had multiple rounds of chemotherapy and had progressed through Lonsurf with bevacizumab, as well as 5-FU-oxaliplatin irinotecan. Okay, so very heavily treated. We met her in 2022, and she initiated on therapy in December. Her first CT at 6 weeks showed a 52% reduction in multifocal target lesions throughout the body, obviously no liver metastases. And interestingly, she developed a tumor flare syndrome. And that was a real problem because the tumor that we didn't know about was in her brain. And by week 24, she had a complete response to all lesions. So this was our screening scan on the right. You can see there's a little something that nobody would have called. Frankly, I don't even know why we do brain imaging in colorectal cancer on trials, but in phase 1, you have to scan everything. And you can see within 6 weeks, a dramatic flare as we have immune infiltration of this. We resected this brain metastasis, and she had sheets of necrosis. She had very few residual viable cells. This is a potent drug. Her tumor marker, if we take you a screenshot from Epic, everyone's favorite software, you can see a dramatic response with plummeting CEA. And so we end up with a patient with a near complete response on long-term therapy who otherwise would have been a candidate for regorafenib, fruquintinib, or hospice. It's a very stimulating result. So what I would say is botensilimab is a next-generation immune checkpoint inhibitor. It is beyond CTLA-4. It is not ipilimumab or tremelimumab. This is something else. It's a 2.0. I think this, we believe, effectively clears regulatory T cells and alters APC function. There's no effect in the liver, and we think we understand why, but we don't know how to address it just yet. That's research we have to do. And I think future immunotherapy trials need to focus on the contribution of organs and how that impacts outcomes. And also importantly, as we enroll patients in these trials, we have to be ready for tumor flares. Bulky disease may be dangerous, and we have to think about cytoreductive strategies and moving these treatments earlier. Higher T cell quality probably means better outcomes. We have to prove that with investigation and funding. But the targeted immunotherapy, I think, is even cooler. And so this is what I really want to talk about. So targeted immunotherapies are bite cells. We try to physically pull a T cell into the microenvironment, or TCRT. We take a T cell and we enhance other factors but leave it native. We have CAR T cell, perhaps the most dramatically effective new therapy. Just to give you a sense, in B-cell lymphoma, refractory B-cell lymphoma, the response rate of a CD19 CAR is 80% with a cure rate exceeding 40% for patients who have not been eligible for other therapy. These are very powerful agents. And then TILs, I'm not a TIL fan. You take some T cells out of the tumor. They weren't killing the tumor anyway, and then we make more of them. I don't think it's likely to work, but people are doing it. And in hot cancers like melanoma, it is working. In GI cancers, I think it's sort of like taking the bottom of the class and seeing if they can work harder. Limitations of solid tumor cell therapy. Number one is targeting, okay? We have to have a target to aim our T cell. If we have a protein, we'll call it Schlechter 1. It's Harvard. You name things after yourselves. And it's present on your cancer. We can kill it with a T cell that aims at that. If Schlechter 1 is present on your brain, that T cell will consume your brain at the same time. Targets matter. Number two is expansion. CD19, where CAR T was invented, has a lot of advantages. You only have adult B cells that are CD19 positive, and your immature B cells do not have CD19. And there's a constant regeneration of signal for tonic signaling of these T cells. You can also just live without the target. I could kill every CD19 positive cell in your body. You'd be fine in 9 weeks. Okay, so target matters. And the fact that it keeps regenerating promotes persistence of these cells. Persistence is a problem if you have a T cell that is sensitive to immune suppression. PD-1 exists for a reason. We don't want our T cells living forever. And so cancer can push back against these products and kill them the same way it killed the native immune system. And so we have to overcome this. We need to think about strategies to promote expansion, promote persistence, promote resistance to injury to these T cells. We have sort of a cartoon of our different products. A CAR T does not have a TCR that matters. We've taken a monoclonal antibody, we stick it to anything we want, and we put a co-stimulatory domain that will drive that T cell. When engaged, it will never turn off. It will run until it dies. We have the native TCR. It has an up throttle and a down throttle. It can turn left and right. It will respond to the environment, but it doesn't hit things it shouldn't. It won't hit Schlechter 1 and consume your brain. And then we have these other things like the TAC T cell product we're going to talk about. You leave the native TCR there, so the T cell does have regulation that doesn't have out of control non-physiologic inflammation. You try to find other ways to convince it to grow. You have a transmembrane domain that will bind to what you want to, and let's say you promote something else like survival and memory T cell with LCK. This is the timeline for immunotherapy to be aware of it. You have to find the biomarker. You need to know if the target exists. That's usually by IHC. Pathologists are still very important to us. Archival tissue is important. You then have to collect through pheresis to get these products. That's placement of a central line and running the entire blood supply through a pheresis machine several times to pull out a population of T cells. The patients then go home. You then have to manufacture this product, which can take weeks or sometimes months, and sometimes the products die and you have to do it again. During that period of time, patients may need bridging chemotherapy so they don't progress and die while waiting for the product. Once the product is ready, patients have to have severe immune suppression, like a bone marrow transplant, to make them ready for this. The reason we do that is to injure the immune system. And as the immune system grows back, there's millions of different peptides and hormones that our body produces, and those can promote growth of T cells. So we use physiologic pathways as a response to injury to make CAR T and TIL therapy grow. And then finally, there's a T cell infusion. It's usually a hospitalization of between 1 and 4 weeks. And between 30 and 90 days, patients need to be near a medical center that can handle the very dramatic toxicity of these treatments. This is a very complicated process. HER2 is the original target for everything in cancer. Most things come from breast cancer. Half of all dollars in cancer research go to breast cancer, and that money is curing cancer. So HER2 is amplified in gastroesophageal junction cancers as well as breast cancer and others, 3% of colorectal cancers. It's a validated marker. We have many tests for it. We even have clinical trials showing that chemoimmunotherapy for HER2-positive gastroesophageal cancer is a highly active treatment. We also know that you can use antibody-drug conjugates. And so as a consequence, the NCI with Steve Rosenberg launched the first second generation of CAR T against HER2. So transmembrane domain, costimulatory domain, and just bind to HER2. And the first patient received rapidly died of toxicity in the lungs. The patient had infusion and developed lethal pneumonitis because HER2 is present on the normal pneumocyte. And the first pass effect when you inject a T cell is to go to the lungs. So this was a learning experience for us. So we decided that HER2 is still an important thing, that we have to be careful about it, but we might be able to do this with some of this other technology. So maybe if we had a more physiologic cell rather than a CAR cell that could control its degree of inflammation, we could do this. So we went after the TAC T cells there on the left, where the TCR is native, and then we find ways to co-stimulate them and promote memory. This is the complex itself. You sort of co-opt the TCR, you kind of shake it up and make it function without it being super physiologic. We pursued a clinical trial of HER2-positive cancers refractory to all chemotherapy. The yellow guys are gastroesophageal cancers. The white ones are everyone else. And you can see a trend towards benefit in the gastroesophageals. It's interesting that none of the breast cancers responded. We don't know if that's because breast cancer patients are heavily pretreated and their T cell quality is poor. We don't know if it's something about breast cancer that pushes back against it, or if it's the fact that gastroesophageal cancer is a bit of a hotter cancer, and maybe there's something to that. But regardless, this is what we saw. It was relatively well tolerated, as you would expect. Pneumonitis was the dose-limiting toxicity that prevented us from expanding beyond treatment, and one patient died from lymphodepleting chemotherapy. That pre-treatment chemotherapy causes profound cytopenias, like a bone marrow transplant, and the patient died of an aspiration event and pneumonia. Here's an example of what we saw, partial response in a gastric cancer patient, chemorefractory disease, HER2 positive, no hepatic disease, interestingly, just nodal disease. And you can see in the pictures on the right side of the screen where you had PET avid disease, which responded by size. Mets will stay avid after CAR because those T cells are in there and alive and doing stuff. So it's kind of a challenge to image these. But this was a clear response and a partial response that was durable. And as we saw in the prior graph, we did have 100% response of target lesions, but there were non-target lesions that remained. Unfortunately, we had recurrence of all patients rapidly. The cells were not good enough. They couldn't survive long enough to be durable. So we showed that TAC T cells could work where CAR T was too dangerous. We showed that efficacy was specific to the tumor type rather than generic, which was actually quite disappointing. It would be nice if we had a pan-HER2 cell therapy. Unfortunately, we had once again, this problem of these hepatic versus non-hepatic disease, probably because that natural process of culling is happening. And because of the PKs of the drug, probably the effective dose and the dangerous dose are too close. So we decided that maybe this is not the right target. This was a lesson learned, but for now, we're kind of tabling TAC T cells. I think there's a future for them. We just have to figure out how. So when we think about target selection, the next big target in GI cancers is Claudin 18.2. Zolbetuximab is now FDA approved as a monoclonal antibody. Claudin is an adhesion molecule. It's between the normal cells. And as the normal cells lose polarity, Claudin 18.2 is hanging out into the environment. And so that seemed like an appealing target for CAR therapy. It was a trial launched initially in China, then pursued in the United States of CT041. This is a CAR T therapy against Claudin 18.2. And it looks okay, right? Things are going down. There's not a lot of complete responses. And the devil's in the details with Claudin 18.2 because there's a lot of GI toxicity. Claudin 18.2 is sequestered between your T cells, between your mucosal cells. That's what glues you together. And if the story I just told you was true, we shouldn't see GI toxicity if T cells can't get in there. But we do. Don't underestimate T cells. They will find a way between your mucosa to cause injury, nausea, and vomiting, and GI bleeding. The other thing to note about this is that expansion and persistence was a problem. There's not enough signal engagement. These patients received 3 rounds of CAR T therapy and did not reliably achieve complete response. So I think it's important to know that Claudin is a proof of concept. It's a cool target, but those limitations of expansion and persistence and destruction of the cancer, I'm not sure that 3 rounds of CAR T therapy with lymphodepletion is safe in the long run. So I do worry about CAR for that target. So we're going to try TAC T cells. Unfortunately, we're in the funding crisis that everyone is experiencing right now. So hopefully funding will come through and we can continue. Now, there's another marker called guanocyclase C. Now, this is a marker that I think is coming closer to prime time. Many people are interested. Guanocyclase C is present on the normal gut mucosa. It's on the luminal side. It's on the poop side, not the basilar side. And the idea was that would sequester T cells from getting there. As you can guess, don't underestimate T cells. It is also present on 99% of colorectal cancers. We screened 114 patients for guanocyclase C, and 113 of them had high expression on their cancer cells. So this is a CAR T design that does a lot of things. There is a CAR that targets guanocyclase C. That's the GCC. There's also a CAR that targets CD19. And you mix them all together, and you get this combination of T cells that are anti-CD19. They're a bystander. T cells that are GCC, okay, they can hit the cancer target, and T cells that are both. And the idea would be that rather than giving higher and higher doses of T cells and trying to find some way to make these persist, to let these T cells expand off of B cells in your blood and persist as those B cells grow back. We're going to slingshot them off of the B cells in your blood, and then we're going to maintain them based on the B cells in your blood. So this is the idea of a dual targeting CAR T. We've pursued this in a 2-cohort clinical trial, and we just actually reopened this week, or last week, I should say. So we consented a patient on Wednesday, which is kind of cool. We had 2 dosing cohorts of 4 and 5 patients. These were slightly younger than average patients. Average age is 40 to 50 years old. Multiple lines of therapy. They had to be refractory to 5-FU-oxaliplatin irinotecan, an appropriate monoclonal antibody. They needed adequate organ function. And they had to have no history of prior colitis for kind of obvious reasons. And they needed smaller disease. We don't want liver metastases inflaming, doubling in size, and causing rupture of the capsule of the liver, and no NC2 primaries. We saw manageable toxicity, cytokine release, high fever, intoxication with the immune system was seen in all patients. We saw diarrhea in 8 of 9 patients. And we saw neurotoxicity, where patients get kind of drunk on their T cells, so drunk they can forget to breathe and require intubation on 2 of 9 patients, though no grade 4 neurotoxicity, just grade 3. And we had 1 patient develop sepsis as a consequence of immune suppression and died of fungemia. That's what led to hold on the clinical trial. And here's our swimmers and waterfalls in group 1 and group 2. This is actually a dose that's very low, 1 million cells per kilogram. And you can see persistent survival with partial response in 1 patient and progression only 1 patient. At dose level 2, we had a complete response. Unfortunately, that was the patient who died of fungemia. And we had 3 durable partial responses, 101, 1114 there on the bottom. This was at the data cut at 6 months. She is now at 8 months with no chemotherapy with highly refractory disease. And so we're going to look at her. She's a 54-year-old woman who presented with metastatic colorectal cancer. She had unresectable disease but was near it. She had upfront FOLFOXIRI and then underwent resection of liver metastases. And she immediately recurred. Like first post-op scan, she had multifocal lung metastases. We managed her with FOLFIRI and FOLFOX, and then she was on Lonsurf with bevacizumab. She underwent infusion of 2 million cells per kilogram of GCC19 CAR T. And actually, she was discharged only 2 weeks in, which is the minimum amount of time required on this. Most patients are in the hospital for 3 weeks. She did have colitis. She had very significant colitis for about 1 day, which we were able to treat. And she had cytokine release storm, that high fever intoxication with the immune system. And she had a near metabolic response by PET by day 60. And she's an ongoing partial response at 8 months. So the key limitations for a GCC19 CAR, in situ primaries are a problem. These T cells could erode through the gut and result in a bowel perforation. Bulky disease is a problem. When you rapidly expand the size of a tumor through inflammation, you may cause injury. Mucosal injury is a problem. Our target is present on the gut, and we need to find new ways to protect the gut from injury. And work is underway to figure that out. I'll be honest, I have lots of ideas. We could talk for 3 more hours, but I'm not going to, as much as I'd like to. All right, so our other products, the other things we have are these native T cells, right? We have T cells. T cells can do things. What if we engineered native T cells? Let that TCR stay the same, but messed with it a little. And so there was the New England Journal paper of the KRAS G12D TCR therapy a few years back, and I will tell you as a GI oncologist, I didn't like this paper because the devil's in the details. One patient out of 308 were found to be a match for this product, and it was a New England Journal case report. The reason it's 1 in 308 is HLA restriction. So we kind of forget about these things, but the way immune therapy works is you have an HLA on your tumor cell, and every peptide in your body is being processed at all times. And little octamers, nonomers, and decimers of peptide are presented for review on the HLA, and the T cells checks it and says, yeah, that's good, and moves on and says, that's bad, and kills it. But it also turns out that not every peptide can be presented. And so as you can imagine, driver oncogenes are probably not things that can be presented, or you wouldn't get cancer. And so it turns out only HLA C0802 can present KRAS G12D for surveillance by T cells, which is to say everyone else can't. That is a very rare HLA type. But if you can find that HLA type, you can create a T cell which is fully, completely vaccinated against KRAS G12D. But unfortunately, all the mechanisms of death to T cells that cancer has in its armamentarium can then just go do this. So yes, you can cause a response, but it will exhaust and will be a transient response. So we tried something different. Turns out TP53R175H is seen in 3 to 5% of all cancer patients, and HLA A0201 is present in about 20% of the Northern European Caucasian population. It's really not present in other populations. But you can take a T cell and you can convince it, or you can engineer into it, that is a TCR, which is anti-TP53R175H. And that should be present on the surface of all of these cancer cells that are that HLA type. And then we armored it. We knocked out the ability of TGF-beta to injure this cell. And so we've infused now 4 patients. They received lymphodepleting chemotherapy after HLA screening and all these things. They then have infusion of the T cells. These T cells are native. They don't function on their own. They have to be given with high-dose IL-2 for 7 days in the hospital. You kind of get the sense of the problem of urban versus rural care here. And we have seen responses the majority of patients seen, and manageable toxicity, although IL-2 is not a nice thing to have done to you. So conclusions about cellular therapy. I would say GCC and Claudin 18.2 are very promising targets. GCC is a mucosal marker. Claudin is an adhesion marker. There's a lot of other markers to consider in those adhesion pathways. CDH117 is an example that a lot of companies are pursuing. Mesothelin-1 was pursued and had to be abandoned because of universal pneumonitis. Conventional CAR therapies are going to be a problem because of signaling. And so my suspicion is that dual targeting, or something called logic gating, up signal, down signaling with CAR therapy, probably has a future to control these things. I think TCR-T therapy is interesting, but it's hampered by HLA type. We're going to have to come up with some way to know which driver mutations and which HLA types are a match across the spectrum of cancer. This is going to require massive investment in HLA typing across multiple ethnicities and races and populations to know the HLA types of patients and to know the peptides that can actually be presented. This should also make you really skeptical about peptide vaccines against common mutations. If only 1 in 308 people were HLA matched to KRAS G12D, please explain to me why we're doing G12D vaccine peptide mutate. Okay, think of it for a second. And I think TCR-Ts are, though, they are interesting if we can find ways to do it with big data. And I think we have to be careful about high-risk features because bulky disease is a problem, primary disease is a problem, and our targeting is a problem. So in conclusion, Cancer normal cells have a lot of similarities that we have to overcome. Cancer evades the immune system both by being immune suppressive against the T cells and also by living in environments that are hostile to T cells. I think immune checkpoint blockade has a future. I think we need to move beyond the first generation of CTLA-4 and PD-1. I think we have to stop averaging immune therapy and make sure that we understand that CTLA-4 is about depletion of regulation, PD-1 is about promotion of survival of the T cells. I think botensilimab probably is our next approved drug in colorectal cancer. I hope that's true. We just need the funding to complete the clinical trial. So if anyone has about $200 million lying around, we'll take it. CAR T therapy, I think, has a future, but we need to be more than CD19 CAR. Okay, this is not just single target CAR. Let's think multi-target. Let's think about up signals and down signals. And the safety profile of these is going to be a challenge for the health systems in the United States. More people die of colorectal cancer every year than are diagnosed with large cell lymphoma. And CD19 CARs, which is only a fraction of large cell lymphoma patients, is a major struggle for academic medical centers to manage. You can imagine the impact of an approved CAR T in colorectal cancer. Fortunately, I'm not an economist. I'm not going to think about that too much. There's a lot of people to thank, in particular Kimmy Ng, who leads the colorectal group at Dana-Farber. She's my mentor, and Rishi Saran is my mentee. It's nice to have a minion who does all the work. Sarah Nicofero and Karen Jacobson lead our cell therapy group at Dana-Farber. Sarah makes the cells, and Karen shows us how to give them to people. Andrew Bullock is our co-investigator on botensilimab. I should also thank Kevin, my husband, who has to put up with me talking about all these things all the time. Thank you very much.